Good evening, and thank you for joining us. My name is Kevin Bergerson, and I am a programs manager for the Colon Cancer Alliance. And on behalf of the patient navigators and the entire patient support team from the Colon Cancer Alliance, I would like to welcome you to tonight's webinar, Latest in CRC, Findings from the 2017 ASCO GI Cancer Symposium. As a reminder, this webinar is being recorded, and all registrants and attendees will receive a link tomorrow evening as to where we have posted the webinar recording. Before we get started, I'd like to give a special shout out to Dr. Laura Porter for doing the creative for the PowerPoint used in this evening's presentation. In addition, I would also like to remind everyone that neither the Colon Cancer Alliance nor our presenter are giving medical advice, and no doctor-patient relationship is intended or established. You should always seek in-person medical advice and make medical decisions together with your individual clinician team. Tonight, we are most privileged to have as our guest speaker tonight and longtime friend of the Colon Cancer Alliance, Dr. Christopher Lieu. Dr. Lieu joined the University of Colorado Medical School of Medicine faculty as an assistant professor in July 2011. He trained in internal medicine at the University of Colorado, where he also served as a chief medical resident. He completed his fellowship training in medical oncology at the University of Texas MD Anderson Cancer Center and served as the chief medical oncology fellow in 2010. Dr. Lieu is a member of the Developmental Therapeutics Phase 1 clinical trials and gastrointestinal medical oncology program. These comprehensive programs include multidisciplinary cancer clinics, tumor boards, and research endeavors. Dr. Lieu is interested in resistance mechanisms to targeted therapy in gastrointestinal cancers, and he was awarded the Conquer Cancer Foundation Career Development Award to study targeted therapies in colorectal cancer. Because of Dr. Lieu's unique gift in conveying complex medical and clinical trial information into easily understandable terms, he has been a guest presenter on numerous Colon Cancer Alliance webinars, and he was recently also presented at our Metastatic Colorectal Cancer Symposium last October in Mesa, Arizona. I know you're going to enjoy his personal style and informative presentation this evening, so Dr. Lieu, with that, I'm going to turn the keys of the castle over to you. Welcome, sir.
Well, thank you very much, Kevin, and thank you everybody for taking time out of your evening to join this webinar. The 2017 ASCO GI Cancer Symposium was held in late January in San Francisco and was an opportunity for researchers, physicians, nurses, nurse practitioners, healthcare professionals, and survivors to come together and discuss some of the latest and greatest research findings in terms of GI malignancies. And of course, we're focusing predominantly here on colorectal cancer. Also want to give a very special thank you to Dr. Laura Porter, who created this slide deck, kind of highlighting some of the really important and impressive talks, scientific talks, as well as research presentations. Over the next 30 to 40 minutes, what we're going to discuss is listed here in terms of key topics. And something that you'll notice is a little bit different than some of the webinars that we've given before is that at GI ASCO, there are a lot of scientific talks to not only inform the research community about some of the breakthroughs that are happening, not only clinically, but also pre-clinically on the bench. And so you'll notice that the first half of the talk really is centered around some of the scientific developments and some of the laboratory research that's being done in colorectal cancer, as opposed to clinical trial results, which we'll talk about at the end of the talk. Why this is important in terms of talking about the epidemiology of colorectal cancer, talking about genetic testing and microsatellite instability, and even talking about some of the bacteria that can lead to colorectal cancer development, is that even though that these may not be treatments or clinical trial results where we're looking at the results of drugs to treat colorectal cancer, we are getting a better understanding of the biology and the science of colorectal cancer. And why this is important is because the more we understand about the disease, the better we can develop strategies to not only treat colorectal cancer, but to also possibly prevent it. So over the next 30, 40 minutes, we'll talk about the epidemiology briefly of colorectal cancer. We'll talk about genetic testing for colorectal cancer. There's a nice presentation by Dr. Stoffel on this. We'll talk about the gut microbiome, how bacteria, viruses, even fungus can interplay with the body and maybe develop colorectal cancer, and why we may be seeing colorectal cancer more frequently in young adults. We'll talk about right versus left-sided colorectal cancer and the differences in terms of response to treatment, as well as some of the molecular differences in colorectal cancer that develops on the right side of the colon versus the left side, and even versus rectal cancer, which obviously develops in the rectum. And then we'll give a brief update on new advances in the treatment for metastatic colorectal cancer, particularly for a subset of colorectal cancer called BRAF mutated colorectal cancer, and I'll give a quick update on the latest on immunotherapy. So with that, we'll go ahead and get started with the epidemiology of colorectal cancer. This is a pie chart basically showing the epidemiology of colorectal cancer and how most of the colorectal cancer that we diagnose in the United States and around the world is what we consider to be sporadic. And what we mean by sporadic is essentially there isn't a strong familial risk of developing colorectal cancer. There isn't a strong family history. In addition, there isn't any known hereditary genetic syndrome that appears to cause the colorectal cancer. So majority of the colorectal cancer that's diagnosed is not related to a familial risk or a heritable syndrome. Having said that, about 10 to 30% of all colorectal cancer that develops is associated with a positive family history or a familial risk of developing the disease. And that's why knowing your family history and your familial risk for colorectal cancer is important. And a lot of this is simply just being aware of it so that you can screen appropriately. Interestingly, when you look at the rest of the pie chart, there are genetic syndromes that are associated with colorectal cancer. We're going to focus a lot here on Lynch syndrome, but that still represents a vast minority of patients that develop colorectal cancer, only 2 to 3%. And there are other genetic syndromes, familial adenomatous polyposis or FAP, and other polyposis syndromes that represent a small fraction of those patients that develop colorectal cancer. So Dr. Stoffel at GI ASCO presented a really nice talk on the utilization of genetic testing in clinical practice for colorectal cancer. And whenever we talk about kind of hereditary or genetic variants, we're talking about changes in inherited DNA. And what was interesting from her talk was that we've identified that in colorectal cancer that's diagnosed in patients less than the age of 50, we can see that 1 in 5 people have an actionable genetic variant or mutation. Now, what do we mean by an actionable genetic variant or mutation? Essentially what that means is that 1 in 5 people have a genetic variant or mutation that would alter how we might screen that individual for additional cancers, including colorectal cancer, but that might also affect how we screen their family members as well, because there could be a hereditary cause of colorectal cancer, which may include an increased risk for other cancers as well. In those patients that are under 35, so obviously very, very young patients that get diagnosed with colorectal cancer, that number almost doubles. And so this is a slide from Dr. Stoffel's talk, looking at the prevalence of these kind of hereditary mutations that they can see on a simple blood test where they look at the DNA in the blood, and they're able to see actionable germline mutations in about 1 in 5 patients diagnosed with colorectal cancer that are under the age of 50. And again, that number almost doubles when you look at colorectal cancer diagnosed in patients younger than the age of 35. And why this is important is because we know that the overall incidence of colorectal cancer in the United States is decreasing. And we suspect that that's due to better prevention, better awareness, and obviously from colonoscopies that can take away precancerous lesions. But what's certainly different about the younger population is that we see that the incidence is increasing. Now, this still represents a minority of patients that are diagnosed with colorectal cancer, but that the risk within the United States appears to be increasing. And this is not typically an age group where we're routinely doing colonoscopies. And so you can see that if 1 in 5 of these patients have a germline mutation, a hereditary cause of colorectal cancer, this is something that we should be certainly looking for. One of the hereditary causes for colorectal cancer, and probably one of the more famous ones, is called Lynch syndrome. This is also called hereditary non-polyposis colorectal cancer. Lynch syndrome is present in the general population in 1 out of 350 or 1 out of every 280 people. It is the most prevalent cancer syndrome. The Lynch syndrome does encompass several different genetic variants. And again, the proportion of patients that are diagnosed with colorectal cancer, only 2.8% will actually have Lynch syndrome. These tumors in patients that have Lynch syndrome are deficient in something called mismatch repair. That's what we mean by the DMMR. They're also considered microsatellite instability high. And I'm going to go over that in a little bit more detail on the next slide. We also know that these tumors are faster growing, and the adenomas, these are precancerous areas, may appear in less than 3 years. And so typically we kind of traditionally think that for a polyp to develop and turn into a full-blown cancer, that process takes somewhere around 10 years, although we know that there's some variation in that. But we know in Lynch syndrome that that timeline can be shrunk down to even less than 3 years. And that's why the screening in Lynch syndrome typically includes a colonoscopy every year. Now, one of the things that we talked about with Lynch syndrome is that these tumors are deficient in mismatch repair. They're called MSI-high tumors. And I just want to explain that briefly, because that also has implications in terms of potential treatment options in the metastatic setting, which we'll talk about at the end of this talk. But essentially, the way I like to describe this is that if I were to ask you to transcribe War and Peace or some other gigantic novel on Microsoft Word, and to do that without a spell checker, you can imagine that when you transcribe all those thousands of words, that you're probably going to end up with a lot of typos because you don't have a spell check mechanism. Whenever our bodies replicate DNA, there's still a spell check mechanism whenever we replicate our DNA, and that spell check mechanism is called mismatch repair. And so if there's a typo in DNA replication, then your body has to be able to recognize that there's a typo there, be able to unwind the DNA, be able to correct the error, and then wind the DNA back up. And that's part of mismatch repair. But when somebody has a mutation that makes that repair mechanism, the spell check essentially, defective, where it doesn't work as well, what happens is that these tumors can accumulate a lot of typos. In other words, they can accumulate a lot of mutations. And so the typical colorectal cancer has about 50 to 70 mutations in the tumor. But patients that have Lynch syndrome or have mismatch repair deficiency, those tumors can have more than 1,500 mutations per tumor. And so there's a big difference between tumors that develop with intact mismatch repair, where they only have 50 to 70 mutations, versus if you have mismatch repair deficiency, where you may have 1,500 or more mutations. And so that's a significant difference. And the reason why that might be important is because those patients that have really highly mutated tumors may be immunogenic. And what we mean by that is that the immune system may start to recognize that cancer, and that's why immunotherapy has seemed to be much more effective in this group of patients, and in patients that have mismatch repair deficiency than in patients that have intact mismatch repair mechanisms. The other take-home point here is that all patients with Lynch syndrome do have mismatch repair deficiency, but not all patients with mismatch repair deficiency have Lynch syndrome. So again, it's more often than not that if you do have mismatch repair deficiency, that you actually don't have Lynch syndrome. But this is a good screening tool because we know that all patients with Lynch syndrome are deficient in mismatch repair. The other part of Lynch syndrome is that colorectal cancer is probably the most commonly associated malignancy in patients that have Lynch syndrome, but we do screen for other cancers. The second most common cancer that we see in Lynch syndrome is endometrial cancer. There's also a higher risk of bile duct cancer, urinary tract cancers, ovarian cancer, stomach cancer, and even brain cancer. And so this certainly is reflected in how we screen these patients that have been diagnosed with Lynch syndrome. So one of the big take-home points from this part of the talk is that based on guidelines from both the American Society of Clinical Oncology and the National Comprehensive Cancer Network, the recommendation is that any patient that's diagnosed with colorectal cancer, no matter their age, should have routine screening for mismatch repair deficiency or screening for microsatellite instability. And so these are based on the guidelines. And so what we'd certainly like to see is that if any patient has been diagnosed with colorectal cancer, that they're being screened for Lynch syndrome. And the way we do that is by looking for mismatch repair deficiency or microsatellite instability. In metastatic colorectal cancer, we also do recommend molecular profiling, particularly for genes that may influence treatment decisions. We look at the RAS gene. We also recommend BRAF in terms of testing for a BRAF mutation in colorectal cancer. Later on in the talk, we'll talk about why that's important, because there may be new treatment options for this particular type of colorectal cancer. And then we can also screen for other alterations as well. I do want to make a quick note to say that there is certainly a difference between genetic testing and the type of molecular testing that we perform on tumors. And so when we talk about genetic testing, we talk about a blood test. We're looking for mutations that can be passed down through generations and can be passed down to the children. We also talk about tumor mutational testing, and this is completely different. When we talk about tumor mutational testing, we're actually doing mutational testing on the tumor cells itself. A lot of times this is done by actually doing mutational testing on a tumor biopsy specimen. The mutations that we find in tumors are not mutations that are passed down from generation to generation. Those are mutations that are specific to that tumor, and those mutations help that tumor to become a full-blown cancer, an invasive cancer. There are different ways to test tumors for specific mutations. We can do targeted tumor testing, where we only perform testing on a few genes that we're interested in. The most common, again, would be RAS, KRAS or NRAS. BRAF is another gene that we test commonly for, and we can also do targeted microsatellite instability testing. There are also just full-blown multi-gene panel testing, where we may test up to 400 or more genes in the tumor. And so we're looking at a broad spectrum of genes, just seeing if there are any alterations in any of the genes that we're testing. And there's certainly companies and labs that perform full-blown kind of somatic multi-gene panel testing. All right, we're going to transition now to bacteria and viruses. And so we're going to talk about how the gut microbiome may influence colorectal cancer. And again, what we're going to talk about is a talk from Dr. Cynthia Spears, who's done a lot of research on how the microbiome, and what we mean by the microbiome is the genetic material of all the microbes that live on and inside the human body. And so this includes bacteria that lives in the human body, funguses, and as well as viruses. And so the hypothesis here is that the microbiota and likely specific members of the microbiome are important to the initiation and progression of colon cancer. And so why this is important is because this is a very complex system within the human body. And we have a lot of patients that ask, how in the world did I ever develop this colorectal cancer? And we kind of give a generic answer where we believe that it's a combination of many factors, including environment, maybe the genes that you inherited from your parents. It could be just environmental exposures, but now we're also including the bacteria that exist in your colon that may lead to the progression and initiation of colon cancer. And so what Dr. Cynthia Spears presented in her talk at GI ASCO was that in mouse experiments, biofilm introduction caused colon tumors to grow. And so you might be wondering, well, what's a biofilm? A biofilm forms whenever bacteria, or really any microorganism, essentially all start to stick together and adhere to a surface. And in this case, it would be a biofilm that adheres to the surface of the colon. And what they were able to show was that biofilms are more prevalent in right-sided tumors. And why that's important is because we know that right-sided colon cancers differ in terms of their response to therapy than left-sided colon cancer tumors. And so what's interesting about this is that the microorganisms that we are exposed to, potentially even from a young age, can contribute to other environmental factors in the development of colorectal cancer. And so this is a slide from her talk from GI ASCO, essentially showing that the hypothesis is that biofilms, so bacteria or microbial biofilms in healthy individuals, can increase the risk of developing a precancerous lesion, an adenoma, or a colon cancer. And so the biofilm formation, and you can see here from this cascade, if you develop a biofilm, you can get decreased barrier function, you can get immune activation, and that can start to increase inflammation within the colon. And you get this cascade of events that can eventually lead to the development of a tumor. And that was the hypothesis from Dr. Sears' current work, looking at microorganisms and the development of colorectal cancer. And so this next slide is complex, but it basically really does show that this kind of adds to what we know about what may cause colorectal cancer to develop. And of course, that includes lifestyle. How much exercise is somebody getting? How much alcohol do they drink? Do they smoke? This also includes diet. We know that diets that are higher in processed foods, high in fat, lower in fiber, can also contribute to the risk of colorectal cancer. We also know that drugs that we take maybe for different other diseases that we're treating can also contribute to this. But now we're also starting to realize that the bacteria that exists within the colon may also lead to the development of colorectal cancer, and that the bacteria that you are exposed to on the right side of the colon is going to be different than the bacteria that the left side of the colon sees as well. And this may start to explain why we're starting to see some differences between right-sided colorectal cancer and left-sided colorectal cancer. So to that point, it's a nice transition to talk about right versus left colorectal cancer. And so one of the updates that we gave at ASCO 2016 was this new data suggesting that right-sided colon cancer will behave differently than left-sided colorectal cancer. And so when we talk about anatomically the right versus the left colon, hopefully you guys can see my arrow here, but the right side of the colon really starts where the small intestine turns into the large intestine right here in the cecum. And the right side of the colon includes the cecum, the ascending colon, and where it makes a turn right at your liver. And the right side of the colon really ends somewhere along the transverse colon where it traverses the course of your abdominal cavity. And then the left side of the colon really begins where it takes a turn down at the spleen, and it includes the splenic flexure of the colon, the descending colon, as well as the sigmoid colon. And of course, from the sigmoid colon, it transitions into the rectum, and we know that cancers develop in the rectum as well. And so this is kind of the anatomical explanation of the right versus the left colon. And what we know now is that the right side of the colon differs greatly from the left side of the colon in terms of how well it responds to targeted therapy. So if your cancer develops on the right side, we know that those tumors do not respond well to a targeted therapy called an EGFR inhibitor in the frontline treatment for metastatic disease. And there are two FDA-approved EGFR inhibitors for the treatment of metastatic colorectal cancer. Those drugs are cetuximab and panitumumab. Those are the two FDA-approved EGFR inhibitors. And what we know is that when we treated patients that developed their colon cancer on the right side and we gave them chemotherapy in combination with an EGFR inhibitor, that those patients actually did the worst. We also know that if the patient developed a colon cancer on the left side and they received chemotherapy and an EGFR inhibitor, those patients appeared to do the best. And so what's interesting about this is that, it's hard to believe that it's just the side that makes all the difference in the world. And so what we know, if you go back to Dr. Sears' talk, we know that the exposures on the right side of the colon in terms of what you're exposed to environmentally, but also the bacteria and the viruses that you are exposed to on the right side of the colon are different than what you see on the left side of the colon. And so we know that this sidedness can serve really as a surrogate for biological or molecular differences between the tumors. And so it's not just that the patient developed the cancer on the right or the left and it's the side that matters. It really is the differences in the tumor biology in the cancers that develop on the right side of the colon versus the left side of the colon. And we know that this has treatment implications. And so when you look at the National Comprehensive Cancer Network guidelines in terms of treating colorectal cancer, what we know now is that within the guidelines, they ask you to take into account whether the cancer developed on the right or the left and to guide therapy based on that. One of the questions that people ask is, well, the rectum is technically on the left side of the colon, so is rectal cancer exactly the same as left-sided colorectal cancer? And so we're going to talk about a presentation from Dr. Mohammed Salam, who gave a presentation at GI ASCO. Just a quick note that rectal cancer is treated somewhat differently than colon cancer. oftentimes patients with rectal cancer may receive a combination of chemotherapy, radiation, and surgery, and so multidisciplinary management for rectal cancer is certainly critical because you want your medical oncologist talking to your radiation oncologist who's also talking to your surgeon so that that team is working together to try and give the best outcome for rectal cancer. And we also know that we can use chemotherapy in combination with radiation therapy to get more treatment effect directly into the tumor. What Dr. Selim presented at the 2007 GI ASCO is a molecular analysis of rectal cancer versus left-sided cancer. And so we know that right-sided cancer is different from left-sided cancer. Is rectal cancer different than left-sided cancer? And what he was able to show was that rectal cancers do indeed have a different molecular feature than left-sided colorectal cancer. And what he was able to show was that there was less microsatellite instability, that there might be actually less of a mutational load in rectal cancer, and there might be a difference in HER2 overexpression. And HER2 is a gene that we can actually target with drugs that target HER2, and so that's why that specific gene is important. And so the take-home points from his talk was essentially that trials should take into consideration the right versus the left side, but also whether it was rectal cancer versus colon cancer, in addition to the molecular markers that we already know about. And this better understanding of disease biology will advance precision medicine. So as we better understand the biology of this cancer, we may be able to personalize therapy better and be able to start offering better, more honed-in, targeted therapies for patients with metastatic colorectal cancer. This is just a slide from Dr. Salem's talk from GI ASCO showing the frequency of microsatellite instability in left-sided colorectal cancer versus rectal cancer. We had talked about microsatellite instability in the earlier presentation from Dr. Stoffel, looking at microsatellite instability and as well as Lynch syndrome. And what's interesting here is that there is a significant difference in microsatellite instability or MSI-H features looking at left-sided colorectal cancer where that's present in about 7% versus rectal cancer where it's only present in about 1%. And so the conclusion from his study essentially was that colorectal cancers do carry a continuum of molecular alterations from right to left rather than having a sharp, clear-cut distinction. And so what we know is that as we kind of traverse the colon from the right side of the colon to the left side of the colon to the rectum, that we do see molecular features that are different, but this exists along a continuum. So we kind of see this kind of gradual change as we go from right side to the left side of the colon down to the rectum. And as we better understand these molecular features, the better that we can serve our patients and the better treatments we can certainly offer them. All right, so that's a lot of science for colorectal cancer. What about treatments? And so I want to talk about 3 treatments that were brought up at GI ASCO for colorectal cancer. And so we're going to talk about BRAF mutated tumors for colorectal cancer and whether or not we can offer better treatment options for this aggressive type of colorectal cancer. We'll touch briefly on heated intraperitoneal chemotherapy for colorectal cancer where the metastasis is predominantly along the lining of the abdomen, and we call that peritoneal carcinomatosis. So this is a surgical technique combining surgery with heated intraperitoneal chemotherapy. And I'll give a brief update on immunotherapy for MSI-H colorectal cancer. So BRAF mutations are present in about 7% of patients with metastatic colorectal cancer. And so why is this important? BRAF mutated colorectal cancer is an aggressive disease. We know that these patients respond less to the current treatments that we have, and we know that overall that this is just a much more aggressive type of colorectal cancer than colorectal cancer that does not have this BRAF mutation. We also know that BRAF mutations can be targeted with a BRAF inhibitor, and so vemurafenib is an oral targeted drug that can target BRAF. And so one might think that if you have a BRAF mutation, and again, this is 7% of patients with metastatic colorectal cancer, and you have a drug that can target that BRAF mutation, that you might be able to just give the patient vemurafenib as a single agent and be able to stop the growth of the cancer. What we know is that this strategy works actually very well in skin cancer, where about half of the patients with skin cancer have this exact BRAF mutation. But interestingly, when we've tried this strategy of giving vemurafenib to patients with BRAF mutated colorectal cancer, that out of 20 patients that were treated with this drug, only one had a response. And so we know that with a single agent BRAF inhibitor, vemurafenib, there's limited activity. And so, instead of kind of a high response rate, we're only seeing a response rate of 5%. So what this shows is that even though we see the same mutation in skin cancer that we do in colorectal cancer, that the responses to this particular drug are dramatically different. And in colorectal cancer, using a single agent vemurafenib alone will not work, which means that there's something else that's going on. This next slide shows you some preclinical studies that were done in a laboratory, and there are actually several studies that have shown this. But that what they were able to show is that when you treat colorectal cancer with vemurafenib, the BRAF inhibitor, what actually happens is that there's a feedback loop. So when you hit the BRAF mutation with vemurafenib, what happens is this pathway that you're seeing in the middle of your screen actually feeds back into this gene called epidermal growth factor receptor, or EGFR. And what happens is, even though you've knocked this gene out with the targeted drug, it just feeds back, and then this activation of this entire pathway restarts. And so what you're seeing here on the graph on the left is treatment on essentially in a laboratory, looking at treatment with an EGFR inhibitor alone, cetuximab, and that's that green line, treatment with the BRAF inhibitor alone, and that's the white line. And what you're seeing here is that even though we're giving these tumors treatment, there's continued growth, and that's why these curves are going up. But if you actually block EGFR and BRAF at the same time, you can get significant tumor growth inhibition, and that's what they're showing here. And then here on the right side of your screen is essentially a similar study, basically just showing that if you can combine two targeted drugs with a chemotherapy, you can actually get these tumors to get smaller. And so this was kind of the preclinical rationale that, well, maybe the BRAF inhibitor alone won't work, but what if we combine a BRAF inhibitor with an EGFR inhibitor and combine it with chemotherapy? Could we get a better response? And so this was a study that was presented by Dr. Scott Kopetz from MD Anderson, looking at the combination of a BRAF inhibitor, an EGFR inhibitor, and chemotherapy versus chemotherapy and an EGFR inhibitor alone. And what you're seeing is that the addition of all three drugs, the BRAF inhibitor, the EGFR inhibitor, and the chemotherapy, slowed down the progression of the cancer significantly. In fact, there is a doubling of time to tumor growth by using all three drugs together. Now, is this a complete home run where patients were cured? Absolutely not. But it does represent the first step in terms of treating BRAF mutated colorectal cancer better. And by using this combination regimen of vemurafenib, cetuximab, and irinotecan, they're actually able to double the time that it took for a cancer to grow. And so this is certainly a positive study and really a groundbreaking study in terms of treatment for this group of patients where we desperately need better treatment options. And so again, this is still a smaller study. It's about 100 patients, but certainly progress forward. I'll touch briefly on a presentation by Dr. Hans Schlitt, who talked about heated intraperitoneal chemotherapy. He described basically some work that he's done showing that patients that have tumors that only exist on the lining of the abdominal cavity, that type of disease is called peritoneal carcinomatosis. And it's just really a fancy way of just saying tumors that develop on the lining of the abdomen. We know that this is a place where colorectal cancer can go. This is certainly a minority of patients. Isolated peritoneal carcinomatosis only occurs in 2% of patients with colorectal cancer. We also know that sometimes you can get this peritoneal carcinomatosis in addition to liver and lung metastases, and this occurs in about 17% of patients. What heated intraperitoneal chemotherapy can do is essentially, this process is where you take all the tumors and you try to cut out as many tumors as possible off the abdominal lining, and then you actually infuse heated chemotherapy into the abdominal cavity and essentially wash the abdominal cavity with chemotherapy, and they call this process HIPEC. And just, as simply as an update, this is a procedure that's been done for many years, but what Dr. Schlitt was able to show was that HIPEC can be successful, and so they can actually get some pretty impressive responses if you select the patients that are going to be best responsive to the surgery and the heated intraperitoneal chemotherapy. And so this is certainly something that's done at several academic centers. You certainly want a surgeon and a team that's used to doing this, that does this quite often. But this process of removing tumors off the abdominal cavity, washing the abdominal cavity with chemotherapy can be a successful surgical procedure, but again, patient selection is the key here. Most patients will not be candidates for HIPEC, but several patients will be, and in those patients you can get pretty good response rates. All right, we're going to wrap up this talk with an update on immunotherapy. Just as a quick review, immunotherapy is essentially using your immune system to fight cancer. You can fight cancer using the immune system either by revving up the immune system or basically taking the brakes off the immune system. And so there are different kinds of immunotherapy, which we're going to talk about on the next slide. So I kind of like to use this analogy in terms of talking about the types of immunotherapy. Immunotherapy has become very big news in terms of media reports. This idea of using your immune system to be able to fight the cancer is obviously one that generates a lot of interest and something that we're very excited about. There are different types of immunotherapy. What we're going to talk about mainly is the brake. So immune checkpoint blockade is essentially the brake on the immune system. Now, brakes on the immune system are usually a good thing, right? We want to be able to eat things and have our body exposed to things without having our immune system go haywire on us, because otherwise we'd just be feeling sick all the time. But we also know that cancer utilizes these immune checkpoints to also hide from the immune system. And so essentially tumors have developed a way to put the brakes on the immune system as a way of saying, don't kill me. If we use a drug that can block these immune checkpoints and activate the immune system, essentially taking the brakes off the immune system, we can sometimes activate the immune system to fight the cancer for us, and that's what we mean by immune checkpoint blockade. And these are the drugs that have caused a lot of interest, and the most common ones that we talk about are nivolumab and pembrolizumab. Those are two immune therapies that are immune checkpoint blockade agents, and they target something called PD-1, or programmed death receptor 1, and I'm going to show you that on the next slide. There are ways of putting of accelerating your immune system by basically pushing on the gas of your immune system, and that's cytokine therapy. These were used a lot in the 1980s, 1990s, and the early 2000s, but there is a way to basically push the gas on the immune system, and those, if you ever hear of high-dose interferon or high-dose interleukin-2 or IL-2, that's what they mean by cytokine therapy, basically pushing the gas pedal on the immune system, but these are rarely used and are not used at all for GI malignancies. And then finally, the steering wheel is essentially vaccine therapies. And so there are no FDA-approved vaccine therapies for colorectal cancer, but certainly vaccines for colorectal cancer are currently being developed. And the idea behind a vaccine is essentially to drive the immune system to the tumor. And so the idea is that, well, if you can teach the immune system to be able to recognize the cancer with a tumor vaccine, you might be able to stimulate the immune system that way. And there's certainly a lot of research going on, but no FDA-approved therapies for colorectal cancer. We had talked about immune checkpoint blockade with targeting PD-1 or programmed death receptor 1. Essentially, whenever a T cell, which is your immune cell, which expresses PD-1, makes a connection with a tumor cell that expresses the receptor, PD-L1, whenever that connection is made, what you're seeing on the top of your screen is that the tumor killing is turned off. And the reason why it's turned off is because this connection between the ligand and the receptor, PD-1 and PD-L1, has been made. And so this is essentially a stop sign for the T cell, essentially saying, don't kill me, just basically do nothing. We've developed drugs now that can actually bind up PD-1. And what happens is that if you have a drug here on the bottom of your screen that can bind up the ligand, well, now tumor killing is turned on because this connection between the tumor cell and the T cell is never made. And so the idea is that you can turn on these T cells and if the T cells can recognize the cancer, they can fight the cancer for us. We know that when somebody is deficient in mismatch repair, that instead of 50 to 70 mutations per colorectal cancer tumor, now they have about 1,500 mutations or more within their colorectal cancer. Why this is important, again, as we described before, is because if you have a tumor that has a ton of mutations, that tumor, your immune system starts to recognize that something is really wrong here. The tumor is really deranged. There are 1,000 or more mutations in this tumor. And so you can actually see immune cells within the tumor whenever you look at the tumor underneath a microscope. We know that this MSI-high colorectal cancer is present in about 5% of patients with metastatic colorectal cancer. So this is still a vast minority of patients with colorectal cancer, but we also know that these tumors in this 5% of the patient population that has colorectal cancer is immunogenic. And what we know now is that these immune inhibitors can be very active for MSI-high colorectal cancer. And so as a single agent, we've demonstrated in several clinical trials that there are durable responses beyond 2 years, which means that it's been past 2 years and the patients are still responding to therapy. The FDA has granted breakthrough status to pembrolizumab for refractory metastatic colorectal cancer that is MSI-high. This did make the NCCN guidelines, so the guidelines now state that you should consider pembrolizumab or nivolumab. These are 2 immune therapies in the second or third line treatment for MSI-high metastatic colorectal cancer. And there are currently studies ongoing looking at immunotherapy in the frontline setting. In other words, can we avoid treating these patients with chemotherapy and go directly to immunotherapy? And again, I want to express this is only in MSI-high colorectal cancer. It's only 5% of the population, but you want to know who these 5% are, and that's why we're trying to really get the word out that we want every patient that's been diagnosed with colorectal cancer to have this type of testing, just so we know. So this is a presentation from Dr. Michael Overman, again at GI ASCO this year. What you're looking at is the spaghetti plot for obvious reasons. It does kind of look like spaghetti here. But this is a really nice way to show the change in the sizes of the tumors and how long we're seeing that response. And so you can, these are only patients with MSI-high colorectal cancer, again, only 5% of the patient population. And you can see with some of these red lines that there are a handful of patients that do not respond to immunotherapy. But you can see from the blue lines, and these are patients that are still on treatment, that there's some patients that have stable disease where the cancer hasn't grown or shrunk significantly, but you're seeing this durable response where it's week 96 and the patients are still on treatment and they're still not having any growth of their cancer. You're also seeing some of these patients having massive responses where 75% of their tumor has disappeared. And you're seeing that some of these responses are truly durable. And again, we're reaching out to over 100 weeks on therapy where you've had this big response to treatment and they're still continuing to respond even 96 or 100 weeks out. And so what we're really interested in is the durability of this response. So if a response only lasts for 2 months, that's still important, but it's still not very impressive. What we really want to see is these responses lasting for a very, very, very long time, and we're starting to see that. And so this data does prove that. And again, a nice study presented by Dr. Overman looking at the combination of 2 immunotherapies, nivolumab and ipilimumab, for the treatment of MSI-high colorectal cancer. So currently, nivolumab and pembrolizumab are having promising results in clinical trials for patients with MSI-high colorectal cancer. They certainly aren't without long-term and late side effects. The main side effects whenever you look at immunotherapy for colorectal cancer is that you can stimulate the immune system to fight the cancer, which is exactly what we want, but sometimes you can also stimulate the immune system where the immune system starts to attack the colon, and that kind of presents itself as a colitis where you may have some diarrhea. The immune system can be stimulated within the lungs, and so you can develop a pneumonia with these drugs, and sometimes you can stimulate inflammation within the liver as well. And so these are some of the side effects that can be serious for immunotherapy, but thankfully they are somewhat rare. We've talked a lot about MSI-high colorectal cancer. Again, that's 5% of our patient population. Well, what about the other 95%? So the question is, can cold, non-immunogenic, microsatellite stable tumors be converted to immunogenic tumors so that they will respond to PD-1 inhibitors. There's a lot of work going on this. One of the studies that was presented at ASCO in June of 2016 was a study looking at a targeted drug, cobimetinib, with an immunotherapy drug, atezolizumab, and that was used in combination in patients with microsatellite stable colorectal cancer. In this particular study, there was a 20% response rate, which is an improvement because we know that the response rate with immunotherapy alone for microsatellite stable colorectal cancer is 0%. And so having any responses with this combination of drugs is certainly promising. And so there are studies ongoing looking at combination immunotherapy trials for microsatellite stable colorectal cancer, because certainly this represents a vast majority of our patients with metastatic colorectal cancer. And just a note from Dr. Diaz's immunotherapy lecture at GI ASCO, when used in combinations, these side effects can be lethal, so we have to be very, very careful. And we certainly want to give this in the setting of a clinical trial where we can monitor safety very, very closely. All right, so that's pretty much what I have for you. These are your take-home points from GI ASCO 2017. Genetic testing, particularly for Lynch syndrome, can be and should be an integral part of colorectal cancer care, and so certainly something that we want our patients to ask our doctors about. The gut microbiome may play a critical role in the development of colorectal cancer and may help explain why right-sided colorectal cancer is different than left-sided colorectal cancer. And we certainly know that right-sided, left-sided, and rectal cancer all behave differently and have different molecular features, and that science is really starting to be fleshed out, and certainly is exciting because the more we understand biology of colorectal cancer, the better we can prevent it, the better we can treat it. There is a potential new therapy option for BRAF mutated colorectal cancer. This does highlight the fact that we want patients' tumors to be tested for this particular mutation because we can plan for it. We can get these patients on clinical trial and maybe offer them something better than what we've done in the past. And studies continue to show the promise of immunotherapy for microsatellite high colorectal cancer, and we're seeing more and more immunotherapy trials directed also to microsatellite stable colorectal cancer, which is also important for the future. And the last slide is certainly a thank you to all the great presenters at GI ASCO. Again, a sincere appreciation to Dr. Laura Porter, who put this slide deck together, and thank you for taking the time out of your day to listen to this talk. I hope you found it informative, and I think Kevin will open it up for some questions at this time.
Yes, very good. That was amazing. Every year we continue to see the landscape change in colorectal cancer care, especially after the two ASCO meetings, and the needle is moving on almost a weekly basis, it seems like, with all the findings. We do have a couple questions here from a couple folks coming in. Our webinars are intended to be electronically interactive, so we'll be taking a few written questions. We don't have a lot of time, but we'll try and tackle some questions as they come in. As a reminder, you're going to get a recording for those of you joining late, an email with a link to that recording tomorrow, so don't worry if you missed anything. To submit a question, click on the small plus sign located next to the word questions on the right side of your screen, and then type in your question and hit enter. We got a couple questions, Dr. Lieu, that came in here. We have one. The first one we have is regarding oral MET inhibitor morestinib in immunotherapy trial combination with a PD-L1 inhibitor. Any thoughts on that combination?
Well, I think this idea of combining any targeted therapy with an immune checkpoint inhibitor is certainly exciting and definitely worth looking into. The idea behind any targeted therapy is that, obviously the targeted therapy may have an effect on colorectal cancer. We also know from the atezolizumab cobimetinib trial that was discussed at ASCO in 2016, we know that the cobimetinib, which is a MEK inhibitor, a targeted therapy, can introduce immune cells into the tumor. And so there's this concept that a targeted therapy might be able to kind of drive some of these T cells into the tumor, and then maybe you can activate them with an immune checkpoint inhibitor. And so the simple answer is we just don't know how effective that's going to be. Certainly the data that was presented at ASCO is still very, very early, but the idea is that it does represent kind of like the next step in potentially being able to offer something very special for patients with microsatellite stable colorectal cancer.
Okay, got another question here. What are the next steps in trial for BRAF? It's the questioner's understanding that there's a study was in phase 1.
Yeah. So it was kind of a phase 1, phase 2 trial. It was only looking at patients with BRAF mutated colorectal cancer. The next steps it's kind of a confusing landscape. It'll be interesting to see what the FDA thinks about the trial that was presented by Dr. Kopetz at GI ASCO. The question is whether or not this is something that we might be able to bring to the clinic, or whether or not we need additional information, additional clinical trial information. And the reason why is because we've been fooled before, where we've had really outstanding results in phase 2, but when we do a much larger phase 3 trial, the results are not as robust as we expected. Having said that, I think the trial results are very, very intriguing. I think this represents potentially the next step in offering something better for patients with BRAF mutated colorectal cancer. Right now, until that's really fleshed out, there are nationwide studies, in fact, worldwide studies, looking at a similar combination of these drugs for BRAF mutated colorectal cancer. And so what my recommendation is for anybody with metastatic BRAF mutated colorectal cancer is actually to get onto a trial, because those trials are open and rolling. And I can tell you that around the world, physicians and researchers are looking for these patients. And basically, it's kind of like the same concept, the same types of drugs that Dr. Kopetz presented at GI ASCO. And so what I would say is that make sure, if you have metastatic colorectal cancer, make sure that your tumor has been tested for BRAF. And if you have a BRAF mutated colorectal cancer, get onto a trial for sure.
Okay, and a parallel question for patients with BRAF mutations, realizing that all patients are different in the final care will be a decision of the patient's clinical team. But are patients with BRAF mutations better off with a combination of nivolumab and pembrolizumab, or with the combination of vemurafenib and cetuximab?
Yeah, so that's a great question, and the answer is we really don't know the answer to that. What I would say is that there is a connection between having a BRAF mutation and having microsatellite instability, having MSI-high colorectal cancer. And so what my recommendation is, again, just kind of in a vacuum, not knowing any other details, is that if you have MSI-high colorectal cancer, you really should consider treatment with immunotherapy, either on a trial, preferably, or off a trial if that's the best that can be available. But in terms of a BRAF mutated colorectal cancer that is not MSI high, right now, immunotherapy should be used really only in the setting of a clinical trial for patients with microsatellite stable colorectal cancer. And so my recommendation is that if you do have BRAF mutated colorectal cancer and you're not MSI high, you're microsatellite stable, it's probably best to get onto a clinical trial.
Okay. I have a question here from a caregiver who indicates her husband has a right-sided colorectal cancer, stage 4, is NED now for 8 months, but just found out there's a recurrence in the lymph nodes. Would like to know your thoughts on maintenance chemo versus, partaking in one of these latest advances and developments.
Yeah, and so, again, it's a little bit hard to answer some of these questions without having the full clinical information. When there's lymph node recurrence, you just want to make sure that the lymph nodes that you see are indeed metastatic colorectal cancer. And in that setting, you just want to make sure that you've done the testing for at least KRAS, NRAS, BRAF, and that you also have MSI testing, because that certainly will affect what treatment options you have available. But more often than not, in these situations, we do start with chemotherapy. We like to be aggressive up front to get as much response as possible. And then after several months of chemotherapy, we like to transition to maintenance chemotherapy, presuming that the disease is well under control. But I guess, as kind of like a general piece of advice, just make sure that you've discussed molecular testing with your physician, how that might influence treatment discussions, and how we typically start is with chemotherapy and then a transition to maintenance chemotherapy.
Quick question here on one of our astute attendees noticed that a lot of the findings have to do with 5% of the population. How exactly will the latest developments that are coming out of ASCO help the 95% of the patients that are without MSI-H?
Yeah, that is an outstanding question. When you start looking at colorectal cancer as a whole, what you're starting to see now is that we're starting to divide up this pie. So if you think about the last 5 decades of colorectal cancer care, up until 1997, there was literally one drug that we had to treat metastatic colorectal cancer. And so, it was kind of like this one-size-fits-all strategy. And so we shouldn't have been very surprised when that strategy worked for some people, didn't work for others. And what you're seeing in the presentation of 7% have BRAF mutated colorectal cancer and 5% have MSI-H colorectal cancer, you're starting to see this pie being divided up where we're maybe able to take 5% and offer them one treatment, take 7% and offer them one treatment. And the idea is that we can continue dividing up this pie where we're not just treating all colorectal cancer as one disease, but we're starting to kind of divide it up into subsets that eventually that 95% might become 90%, might become 80%, might become 70%. I think in terms of where we are right now, just in terms of microsatellite stable colorectal cancer, the true advances that we're starting to see is with this combination immunotherapy. And so what Dr. Bendel presented at the big ASCO meeting in 2016 was this combination of immunotherapy with a targeted therapy. And this was in patients with microsatellite stable colorectal cancer. And so, kind of if that strategy does work for a subset of patients, again, that's something that we could start offering maybe the 95% of patients with colorectal cancer. But it is one of those things where it's a very astute observation. It's absolutely the frustration when it comes to, colorectal cancer research and wanting to really push the field forward. But the real hope is that if we can start subdividing, take 5% out here, take 7% out here, take another 5% out here, that we can really start chipping away and offer more personalized precision medicine for colorectal cancer.
Excellent. Had a question here. This will probably be our last one because we're just flat out of time, and there's lots of great questions. We'll follow up by email with any questions that we didn't get answered this evening, folks. But is there any information out there, Dr. Lieu, about ethnic groups that are affected more by right versus left? Is there a predominance being displayed in a breakout sense for ethnic groups in the data?
Yeah, that's a great question. I think that data is emerging. We may actually get more information at this year's ASCO, in Chicago in June of this year. Right now, we certainly know that there are certainly ethnic differences, for colorectal cancer as there are for a lot of cancers. The question really is there truly an ethnic difference between right-sided and left-sided? And I don't think that we've really been able to kind of hash that out, or there isn't anything really definitive. Right now, the answer is we really don't know. But it does kind of bring up this idea of, well, could there be different environmental exposures and diet exposures and lifestyle exposures that may predispose one ethnic group to develop more right-sided versus left-sided cancer? But the answer is it might be a little bit too early to tell right now.
Well, thank you very much, everybody, for all of your questions, but we really are out of time. We tried to pack as many questions as we could. There was a lot of information coming out of ASCO this year, and we will reach out to you if we didn't get to your question. We'll answer those questions and get back with you by email. As a reminder, all of you will receive a follow-up email tomorrow with a link to this recording to where you can find that recording online, and you can review this presentation in its entirety at your leisure. In that same email, you'll also get this link that was found where you will get a survey and let us know how we did. Please let us know and be brutally honest. Next month, join us for our next webinar, Palliative Care and Making Quality Life Medical Decisions. Registrations are going to be open real soon on our website at ccalliance.org. You can find that in the news and webinar area located in the Get Information section where you can find out how to register. Before we go, if you have any questions, challenges regarding financial support or treatment questions, anything you may want to ask, or you want a more one-on-one personal setting, you can call our helpline at 877-422-2030 and speak directly with one of our certified patient and family support navigators. Or you could talk to them live online via live chat at ccalliance.org. Thank you, everyone, for attending. We hope you enjoyed this webinar. I would especially like to thank Dr. Laura Porter for arranging the presentation slide deck, as well as Dr. Christopher Lieu for his most excellent presentation. If you have any questions regarding the webinar, as always, feel free to reach out to me by email at kbergerson@ccalliance.org. On behalf of the entire Colon Cancer Alliance team, I'd like to thank everyone for attending this webinar. I hope you found it informative and value added. Have a good evening and take care, everyone.